One. Please start. We are live.
Namaskar and good evening, everyone. A very warm welcome on the second day of Current Oncology Update Series, Part 6. And with immense pleasure, I would like to invite Dr. Rajat Bajaj, who is Senior Consultant Medical Oncology, Fortis Hospital, Noida, to set the ball rolling and for the welcome and introduction. Over to you, sir.
Yeah, am I audible?
Yes, sir.
Okay. Good evening, everyone. I thank you all for joining in on day 2 of this current oncology update series, which is on lung cancer. Yesterday, we spoke about the gynecological malignancies and we discussed the nuances of the newer updates which have come up in endometrial, ovarian, and breast cancer. We'll be trying to do the same today with lung cancer, with so many new things coming up in the recently concluded ASCO 2022. We all as oncologists know that this is an ever evolving field, so we should keep ourselves updated, and this is what the effort is going to be in the next 2.5 hours or so. So without any further ado, I would like to call upon the moderator of the panel discussion this evening, which happens to be on managing early stage lung cancer patients, a case-based discussion. We have with us Dr. Arvind Krishnamurthy, sir. Sir, of course, is somebody who doesn't need any introduction. He's the professor and head of surgical oncology at Adyar Cancer Institute. Sir, good evening.
Yeah, good evening, Rajat, and my pleasure to be a part of the panel.
So, sir, can I call your panelists?
Yeah, I'll do that. I think if they can allow me to share screen, and yeah, you can do that also.
Okay, okay. So we have with us Dr. Darlong. Hi, sir. Dr. Darlong.
How are you?
Hi, sir. Hi, I'm good, sir. Hope you're doing well. Dr. Bilal Asif from Gurugram, Medanta, Gurugram is there.
Hi, I'm there.
Hi, Dr. Bilal. Dr. Shubham is there. Dr. Shubham.
Hi, Rajat. I'm there.
Hi, good evening. Dr. Pasricha is there, sir. Good evening. And Dr. Amit Janu from TMH Mumbai.
Hello,
and then, of course, I'm myself there to help in the medical oncology cases. So, sir, over to you.
Yeah, I think the organizers you have to allow me to share screen. Yeah, if you, because they've disabled me. So,
Support
Pooja,
team, please help out. Yeah. Support team, please help out so that they can share their screen.
yeah, I'm sharing from my end. So if you could enable me, I think that'd be great. Anyway, it's a pleasant evening, and I think it's all familiar faces. So I think we are meeting in the online world, the extension of the COVID times, although it seems to be slightly on the lesser note now. Yeah, still I'm not
able to. Okay, support team, Vinay, can you just allow? Can you enable the sharing screen?
So interesting panel, actually. I just realized that there is no radiation oncologist in this, so we can do away with one question, that is, right?
Right.
If Rajat will allow us, yeah, that's true.
No SBRT, huh?
yeah, I think they've allowed me to share. Great. Perfect. Yeah, am I audible? Screen, everything is visible?
Yes, sir.
Yeah, it's visible.
Yeah, great. I think this is the eminent panel, as Shubham said, no radiation oncologist, but still I think we should sort of dwell on that topic. And I thought rather than going for the regular case scenarios, which I'm sure that most of us have done, I thought I'll just give it a little twist. So let's see how it goes. Of course, just to set the background right, this is the latest TNM staging. Maybe I just start with you, Shubham. Early stage, I think, what is your take on early stage, and where could surgery be given as an option?
So, sir, the early stage I would consider to be anything less than 2 centimeter with node negative would be the ideal, the definition wise early stage. but the current clinical practice allow me to actually take up to 3 and N1 to be early stage with the amount of extensive disease that we see. But book wise, it should be less than 2 centimeter and more beautiful.
Great. Yeah. 2 centimeters, maybe the segmentectomy cut off, Dalal, just to sort of get you also in, where all we should do we sort of, in which stages can we extend surgery as a part of the treatment, either single modality initially upfront versus say multimodality, just to set it.
I think, Arvind, you've brought a very pertinent question. We are still stuck in that stage of early stage and locally advanced. I think as Mo has clearly stated that it's basically early stage and unresectable stage 3. So I think anything which is stage 3 N2 disease, which is resectable, is basically now in the early stage. It is clearly the unresectable one is basically the locally advanced. We'll take it out.
Great. I think maybe the consensus would be that up to stage 3A, maybe you could sort of, do upfront surgery. But Shubham also had a point, because a lot of exciting data coming in the sphere of very early stage, if at all I might call this less than 2 centimeters, and we'll come to that in due course. It's just the case, and I think everything will revolve around this case. A 58-year-old gentleman, PS1, never smoker, underwent a left upper lobectomy with a systematic mediastinal lymphadenectomy in 2017 for a 1A adenocarcinoma. So I think I just want to get Amit here. I think what is the follow-up protocol? How often do we do imaging or history, or what is it that you have for us, Amit? Yes.
So basically, it is a stage 1 adenocarcinoma.
Right. He underwent only surgery, of course, because of 1A. No other treatment was there. The treatment was curative. So what is the follow-up protocol that you normally sort of would advise?
Okay. So basically, we start with the 6 monthly, and then we, if there is nothing is there, then we go 1 yearly and then 5 yearly. Any practice change in Shubham, you see in your practice?
No, similar ones, but somehow patients themselves, even if we don't ask them, they end up getting a PET scan at their own end after every year just to ensure themselves and us that they don't have a cancer. So somehow this PET scan is coming up, and believe me, it's throwing surprises. When you don't expect recurrences to occur, they are showing up. So I don't know if it's correct or not, but yeah, we follow the same.
The CT is the, we do follow with the CT. We are currently not doing the follow with the PET CT.
No.
Yeah,
we are not.
Maybe Dr. Bilal, what is that the same your practice? How do you follow up?
At least for the first 2 years, what we've been following is a 6 monthly CT scan. But when it comes to when we reach that annual mark, and then thereafter, probably sometimes we are keen on getting an annual PET scan done, because sometimes you do find nodes cropping up here and there, and that becomes an issue in some patients. So for us, it is for the first 6 months, until the annual, it's a CT scan, and then annually it is a PET scan.
Amit, any thoughts of low dose CT scan as follow-up, maybe in the later parts? What is your take on whether we can do away with the contrast and just do a low dose CT scan as follow-up, maybe after 5 years or so?
So basically, low dose CT is to pick up parenchymal abnormality. It is not meant for picking up any nodal disease or a visceral disease or any bony metastasis. So basically, it is just for a screening tool. We are using low dose CT to pick up any abnormality that is there in the lung. Not in the follow-up scenario. At present, we are doing it. But maybe in future, if the techniques are well developed, maybe we are able to do that. But definitely at this point, no low dose CT for follow-up.
Great. I think very interesting points. I thought I would start off with this because, this is a very important sort of, phase. There is a slight difference between the guideline and what real world we tend to practice. As Shubham rightly said, patients are keen. They even during follow-up also, they do get PET. But the guideline generally, as most of you all said, 6 monthly for the initial phase to do a regular CT chest. And then maybe after 5 years, or after 2 years, then yearly. So, but this gentleman, of course, after 5 years, he had a CT chest, of course, not a non-contrast, means a contrast one only. But there is some little exciting data on having low dose CT scan, especially because some of them may be smokers, so as a part of an extension of the screening in terms of follow-up of some of these patients. But as Amit said, there's no hard data to substantiate that, and it's in a phase that we are evolving, considering the fact that we do have long-term survivors, and to keep exposing them to contrast CT scans every 6 months in the initial phase and every year is going to be a challenge later. So to cut the story short, for this gentleman, he had a left upper lobectomy, the left lung, everything was okay. It's a regular CT scan. He showed about it was 1.8 into 1.5 centimeters. This time it's a right lower lobe lesion, a sub-centimeter mediastinal nodes, and I think I just throw it up. Maybe Shubham, you can go, and then subsequently others can sort of chip in. How do we go about evaluating?
So this was a CT scan. I would want to get a PET CT scan for this patient to look for the activity in this nodule, and also for any other possible site of disease.
Great.
But Shubham, I just have one question. How does the activity will change your management? Because on imaging, if it looks to be suspicious, probably because it is lobulated and have speculations.
No, but if the nodes are also suspicious and there is one more lesion in the bone, then it will change my management. That's why, especially for restaging, a PET is very important. Probably if everything is normal, then the PET will not change, and that is where probably I would want to get in the biopsy is not useful. But definitely, if a patient comes up with a suspected recurrence, in a case where I know the systemic disease can be present, especially lung, I would want to get a PET scan done before I intervene.
Yeah, there's no doubt about doing a PET CT. I think a lot of people may definitely do a PET CT as a part of the staging. Dr. Darlong, anything else? I think the next other issue is regarding the biopsy for this gentleman. What would be your normal practice? It's a peripherally placed lesions, less than 2 centimeters.
I would first go basically for a biopsy, a tissue diagnosis first, before I start investigating for a malignancy. I think we need to basically go and do a biopsy, confirm it, and once I confirm, I'll do the rest workup, metastatic workup, a PET scan, MRI brain, if it comes to be malignant.
Yeah, Dr. Belal, is that your practice, or would you say that?
No, I would agree with
I
would agree with Dr. Shubham's take, because PET CT scan will give us maybe more targets also. So even before the biopsy, my point of view is that if there is a lesion there, and if there are other lesions that can be addressed in the same setting in the biopsy, so it's important to get a PET scan before we proceed.
Yeah, we did get a PET scan before for this. My only issue was would you go directly for surgery based on clinical radiological grounds? What is your take? The consensus? Amit, you want to add anything?
Yeah, I think before we cannot go on clinical radiology because PET can highlight anything. Any inflammatory disease can be picked up by PET. It is maybe bright on PET. There may be lymphadenopathy because we are living in a country where the endemic infections are very common. So if one doesn't have a biopsy, I think surgeries could be sometimes futile. So basically, we have to prove what we are dealing with, whether it is a recurrence or it is some metacoronous tumor, which maybe it is or maybe it is something else. And then we will proceed with the staging and then MRI brain staging.
Perfect. I just brought this point because sometimes the NCCN guidelines, they say that when the lesion is sort of peripheral, clinical radiologically, it's suspicious, you may go for surgery. You wedge it at the time of surgery to a frozen section and sort of proceed. But I guess most of the times, I think we as practitioners would sort of be comfortable. And herein, I want to bring Dr. Sunil. How do you sort of know the yield of some of these lesions? Are you really happy with FNA in this scenario, or do you want some more tissue, Dr. Sunil? How is your, what would you be comfortable?
Definitely, we will be comfortable if we are going with a biopsy rather than a FNAC in this, because that will be a single procedure, and that will let you know not only the diagnosis but also the subsequent whatever investigation that added immunohistochemistry upfront on that. So definitely, I think a biopsy should be the choice of the procedure first.
Right. Amit, in your setup, are you able to get good cores for biopsy in some, of course, this lesion is about 1.8 centimeters. What is your yield in such of these lesions?
Definitely it is a straightforward biopsy. Sometimes the issues could be pneumothorax, but we have a data which we have audited. It is around 4,000 patients, and in which the yield to get a tissue with a molecular diagnosis, was around 96%. So definitely out of them, there are around 70 lesions which are centimeter size. And in that also, it was around 92%. So I think it is fair for a image guided biopsy under CT scan, one could get the diagnosis.
That's in our experience also, very rarely that we have to advise for a repeat biopsy, because I think in more than 95% of the cases, a single biopsy, the biopsy which is done upfront, that is sufficient not only for the diagnosis but also for the subsequent testing.
Sir, Dr. Sunil, may I ask you that would you be happy if the surgeon sent a wedge and asked you for a frozen section and to tell us whether it's first a cancer, and if a cancer, whether it's a adeno or a squamous? Would you be?
Yeah, we'll be happy to report frozen section also, because with experience, the accuracy in the frozen section is quite good. So we will not have any problem for the frozen section.
Great. No, we have wonderful IR people, wonderful pathologists and cytologists. So I think life becomes much easier. But I think it's really heartening to note more than 90% tissue yield with sub-centimeter or centimeter sort of lesions. It's of course it may not always be the case in many centers across, but I guess I think we are getting better on that, and the yield definitely is improving. The other issue to my surgical colleagues is, of course, we did a biopsy. It came as adenocarcinoma. Would you sort of want to do any molecular markers upfront? Do you want to know anything at all right at this point of time? Would it change your management in any ways? Maybe Shubham, you can start, and then Dalong. And
so I think I would be interested to know on a biopsy whether it's a squamous or adeno. I think initially it was a squamous, so which will help me understand, if it's a completely different pathology, then I can be very sure that it's a second primary. Squam, I would, obviously the time period is 5 years, so I would still consider it as a second primary, but it would be interesting to know whether it was squam to begin with and now became a adeno, or was it a squam. So that way, I'm not sure it will change management, but that will be interesting to know. Molecular markers not at this point in time.
Great. Would that be the case, Bilal?
I think yes, we'll follow more or less the same parameters. But as we had several discussions with our oncology colleagues who would like us to, get the markers done right in front, because then the post-operative, if anything, particularly in the light of the newer evidence that is coming through, things become much more streamlined in some cases. So maybe in discussion with the oncologist, we might be, asking for the markers in the panel.
So my understanding is you all will do a biopsy. In this case, of course, it was an adeno initially. This time also it was an adeno, possibly a second primary, considering the fact that it has been about 5 years. But more often than not, we would not wait for the molecular markers, but we will still proceed
Definitely.
to our management. And in this particular case, I think it's interesting, since he had a left side systematic mediastinal lymph node dissection. What is your take on mediastinal staging for this gentleman? Maybe Dr. Bilal, you can take, or Dr. Dalong, you can take it first, and then.
I didn't get a PET scan finding whether mediastinal nodes or not.
No, they were not. They did sub-centimeter nodes. Only the lesion.
Mediastinal node. This is a second primary. I would prefer to go straight for surgery. A negative PET with negative mediastinal node, go straight for surgery.
Perfect. Some background noise is there. I'm not sure. Maybe the organizers can sort of check out and mute that part. But yes, would that be the consensus, Dr. Bilal and Shubham?
Yeah, I would agree with that.
Perfect. Yes, I think. Shubham, you wanted to add anything?
Yeah, no, sir. I think I'll go with the same approach. Love to get into a surgery.
Perfect. I think because generally for lesions that are peripherally placed, less than 3 odd centimeters, I think a good PET would be reasonable, and the chance that you're missing out may be very, very less. So I think the traditional recommendations is to avoid any sort of formal minimally invasive or invasive mediastinal staging. And now I think it's the $1 million question as to how to go about this approach. Of course, SBRT I had to put, but then I guess maybe we would sort of drive that discussion also, like considering the fact that the gentleman has had a left upper lobectomy initially. So how I possibly, let me start off by saying what functional evaluation, I'm sure that it is mandatory for this gentleman considering that he's had a sort of surgery. How do we go about in this particular case? Dalong can take it up, and then the others.
Me?
Yeah, or anybody.
Okay.
I think it's just open to you. You all take it. And
yeah, I mean, I think we all go basically for a complete PFT with DLCO and a cardiac evaluation. That's the basic, I think.
Right.
No, and the PFTs becomes more important for this because this patient has already lost, almost 5 segments of a lung because of a left upper lobectomy. So 4 segments at least. So it becomes more important that we get a PFT done for this because it will have an impact on the next surgical decision.
Perfect.
Absolutely.
Yeah, maybe one of you guys can comment about SBRT also, like, considering the fact that,
So
this, like, assuming that the functional evaluation is okay, say your FEV1 and your DLCO were more than 60% of the.
Yeah,
Yeah,
I think
so
we
I
can add one
think-
option other than SBRT also, it is like ablation. So definitely because it is less than 3 centimeter, ablation is also equally effective. It is not hitting any of the surfaces and there is node negativity. So ablation is also, if surgery is not feasible by any means, then SBRT and ablation option should be given to the patient.
Amit, in that way, maybe you can sort of give us a little more, sort of throw more light on what data is available from the ablation perspective. Yeah.
So I think there is a Rapture trial in which they have compared with the SBRT and this thing ablation, and it has proven to be superior in this thing. So locoregionally it is well controlled, and in terms of distant metastasis also there are similar differences. So probably ablation is coming in a big way, especially in the setting where surgery is not feasible. And we have our own data mostly for metastatic disease, but we have done around 20 per se for primary disease. And we have patients which are living for more than 5 years and locoregionally controlled without any distal metastatic disease. So I think that is also a very feasible option.
Dr. Amit, ablation with radio frequency?
Yeah, so we don't do cryo because cryo probes are very heavier and the chances of pneumothorax are relatively higher with them. But it is RF ablation. So if it is something which is less than 3 centimeter and node negative, that is an option.
I have some question regarding RF and microwave. I thought microwave is the much preferred one compared to an RF.
So microwave, we are using it when it is near to the vessels and some neurovascular bundle. So we are using it for that location. If it is in the periphery, RF is also an equally good option. So both are ablative modalities in that sense.
Great.
I think it's very important. So we had not exactly a similar case, but 3 years down the line, somebody we operated had another lesion in the opposite side. And I think patient preference also needs to be taken into account very importantly. And it's very important to sort of discuss with them the option that you do have an option of, SBRT as well, or other ablative therapies, because my patient, did not choose surgery because they didn't just underwent. So he chose SBRT for that. So I think it's a very important perspective to have the patient's, input on this.
You had the nail.
But really, I feel so surgery should be a problem with this patient because he has had a good outcome. 5 years down the line, he has come back with a very small lesion. I think the patient would, and I'm sure you would have done a surgery.
Right. So I think Shubham is really convinced for pushing for surgery. That's what I think it would have been interesting to have radiation oncology as well. But Amit did sort of did the balancing act by introducing a third aspect of RFA versus microwave. But I do contend, but then say in a recurrent setting versus a primary case, are there certain concerns at the back of their mind? And then Bilal did sort of, raises how confident are you to sort of in your counseling? Maybe Dalang, you can have the final say on this. Like, whenever you counsel your patient for a resurgery, like in this particular scenario.
See, I mean, in this particular scenario, it's after 5 years.
Right.
So a different, different pathology. So I'm very much convinced that, surgery is the appropriate treatment for him. Adenocarcinoma, you can have basically stars, concept of stars is also there. So, that is not taken care of by RF or microwave, SBR and all that, you cannot. We're trying to basically try giving cure. The problem with SBRT is that it's equivalent, we know it, but we don't talk about local recurrence. When you treat the local recurrence, you can say, okay, you're going to give you SBRT and surgery, you have the same survival, but you have more chance of recurrence with the SBRT, but they're going to treat you. So your survival will be the same. So, it's basically like one shot treatment versus multiple, cocktails.
Perfect. I think I like both of you all aggressively pushing for surgery, but nonetheless, I think we take Bilal's word. Also, we sort of take into consideration the perspectives of the patient as well. Just to put it in all perspective with regards to SBRT, because the radiation oncologist is not there, and Amit did mention, like, if it's a fit patient, I think that's the most important thing. Then I guess the evidence points, at least whatever little randomized evidence is there, it's a poor quality. Meta-analysis, almost 8 of them are there. The last 2 strongly pushing for surgery. Propensity matched, slightly mixed results, but majority of them pushing through surgery. So for now, I guess, the evidence is put together, the poor quality, randomized, the high quality meta-analysis, and some propensity match at least seems to be favoring surgery. Definitely, as Amit said, that if the patient refuses for some reason or for reason, so if it's medically inoperable, then all these options are definitely there. Just to move around, and this is Shubham's less than 2 centimeters. So now what, like the extent of surgery for this particular, and this of course is you may do it in either ways, a functional evaluation, but I think this was already discussed. Depending upon the scores, the percentages in FEV1 and FVC, we would sort of, subsequently escalate to shuttle test and CPET appropriately based on the risk stratification, either a low, moderate, or risk, and then take it up for surgery. Now, the extent of surgery, and that's the big thing that has happened, and Rajat wanted us to sort of, talk about this, like how to go about here. Either ways, I think Bilal, you can take it, then subsequently.
Yeah, so I think in this particular scenario, it's a small lesion, 2 centimeters. We can, if expertise is available, and if you can do a segmentectomy, I think I could go for that actually.
Perfect. Segmentectomy. Dalong?
See, we have talked about evidence, the present Japanese and all that. That is in the context of basically ground glass lesions. It is not basically for really solid lesions. It is in that area where they have got very much common ground GGOs. And the criteria is very, very strict. We have to understand that when they do systemic segmentectomy. If we can follow that criteria, I think, yes, it's a valid option. But how are we really following it? That needs to be seen. They do a lot of frozen, the margins, many things are there. And even the trialist, he said at the end, the mismatch was basically because of some fault. There were more patients who died because of cardiac and respiratory and neurological complications. Otherwise, the recurrence, local, all these things were much better they were lesser on the lobectomy arm. So I am very, very still much skeptical about the present trial that we have. I would always prefer to go for a lobectomy, unless it's a GGO, where part solid 50, less than that. And with a borderline respiratory function.
So my concern is always with the CT ratio. They always tell us that the CT ratio should be almost 1, but for the JCOG study, they made the CT ratio to be 0.5, which increases your inclusion criterion. You can get away with doing a smaller surgery. With the 2 centimeter lesion, if you were to take a CT ratio of even 1, it will make it almost 6 centimeters, so segmentectomy goes out. So I think segmentectomy is like Dr. Darlong said, should be related to sub-centimetric or a maximum a centimeter lesion, but 2 centimeters is actually stretching it. But if the PFT is not good because the patient has already lost a lobe, I might be really tempted to look at a wedge resection, because the CalJB data actually showed that you can get away by doing a wedge resection. A non-inferiority trial, they were squams, smokers, so all those things. But again, that would be my second choice. The first choice would be still to go for a formal lobectomy, but I would want to see the PFTs. If not, then probably a wedge.
Perfect.
Yeah, so probably
Yeah.
it is very important for in this particular scenario to understand that there is a left upper lobectomy already done, and and in that situation, as Dr. Dolang pointed out, and I insisted on that also, that if the technical expertise is available and if you're able to really do the justice, then I think segmentectomy can be a fair option. But as said, I mean, for other cases, no doubt about that, lobectomy of course is the better choice wherever feasible.
Great. I think a lot of discussion, and you all have elegantly brought about almost all the points that I had actually thought of discussing. Just to sort of put it in perspective, now you have some more evidence, like almost 1,800 patients now we have. Less than 2 centimeters, and this is the first sort of study that actually showed that overall survival was actually better. But then, as was pointed out by Dalong also, that they had to do frozen sections, they had to make sure that it's truly N0, then you had to have a clear margins, 2 centimeters all around. And as you also rightly pointed out, lots of, although recurrences were slightly more in the segmentectomy arm, there were a lot more deaths, and the deaths were not related to cancer. They were sort of cardiac and for some other reason. So I think it's we really need to sort of dissect this trial, and as was done. So I guess the jury is not completely out, although this is exciting data. This is good, but I guess there would, if the PFTs are reasonably okay for a lobectomy to be done, then possibly you may go ahead. But in case there is a concern about the pulmonary function test, then you could sort of do a segmentectomy. Shubham did mention about wedge resections, considering that 60% of the patients in CalJB, but I really wonder, so whether you can possibly do that. But then if people are doing SBRT and microwave or RFA, then maybe that is even a wedge also is something. But then I guess pure oncologists would sort of favor to do a more anatomical lobectomy whenever it's feasible. Of course, these options are there, so there is an exciting option of doing lesser than lobectomy in terms of a segmentectomy or a wedge. I think this is possibly the sort of the advance that's happened in our understanding. Of course, this trial, although it's a randomized trial, first trial to be proven, but we do need to sort of study the patterns of failures and the patterns of the outcomes, what factors influence. All these things are important. So very few people would actually change practice remarkably, but this is something that is a food for thought. And of course, people who are interested can read the entire article that was published in Lancet earlier this year. And of course, that now say say when we did a formal lobectomy, and I would want to bring Rajat in, because they have sort of brought us all together in this platform. So say that there is a 1 hilar node positive for this gentleman, it's an adenocarcinoma, again T1A. Now what, Rajat? And I think we sort of have discussed enough, and now I would sort of leave the stage to you, and to sort of take it up further. How do we go about it? It's a stage 1. It will be stage 3 at this point of time, considering one of the hilar node is positive. Yeah.
Yes, so this is going to be stage 3, and when it is stage 3 and adenocarcinoma with an R0 resection, we are going to look at these certain molecular markers, and it is going to be EGFR. As of now, it is going to be PDL1 as well. These are the 2 molecular markers which are valid, and then certainly this patient becomes a candidate for adjuvant therapy if the performance status allows. Even the guidelines say that adjuvant therapy has to be given. There is at least 3 or 4 options of platinum-based doublet which can be given, depending on whichever trial one would really like to choose from the available data. Also, in my practice, about 70% of the patients do have a performance status which is good enough for them to receive adjuvant therapy. And after adjuvant therapy of chemotherapy has been given, then if the EGFR is mutated, these patients will end up receiving osimertinib. If the PD-L1 is high, then these patients will should be given the option of atezolizumab. Osimertinib is according to the ADAURA study, and atezolizumab is according to IMpower 010 study.
Rajat, you elegantly summed it off in a couple of sentences. My only take is that, of course, adjuvant chemotherapy for sure. And how many of your patients, have you completely changed your practice, considering immunotherapy for some of the, so you give immunotherapy for the EGFR negative patients, and for the EGFR positive, you sort of go the ADAURA way, or how do we sort of decide in your clinical practice, and do all your patients go the ADAURA way, especially if they are EGFR positive?
Yes, so ADAURA is a trial where we have almost jaw-dropping Kaplan-Meier curves, if I have to really put it that way. These Kaplan-Meier curves have not been seen in many other trials. I can probably think of LX in ALK positive Nsclc. I can think of one or two others in the other setting. But then with such a wide difference in the experimental and the control arm, I will certainly like to go the ADAURA way if I have a EGFR mutated patient. Having said that, there is a criticism that this is still a disease-free survival, which we are really looking at. We don't have the overall survival data. How sane it is to really base our treatment protocols in the adjuvant setting only on DFS and not really wait for OS is something that can be debated upon. But still, because we are dealing with a disease which does not have a very good survival, there are chances of recurrence, even with a disease-free survival where the hazard ratios are less than 0.4. I will certainly like to go ahead with osimertinib.
Right. And just to point out, I think the trial in the duration of osimertinib was around 3 years or so. So what is the, do you have any toxicity concerns, or what's your experience?
3 years.
Good evening, sir. Sorry to intervene. Request you to kindly conclude, please.
Perfect. I think the organizer has the final word. Rajat, I leave it to you, and then we can sort of conclude.
No, we can continue. We can continue. Not an issue. So, sir, I think osimertinib is a molecule which I think most of the medical oncologists will agree is a very well tolerated molecule. Patients generally do not have any issues with osimertinib. There can be some patients who would have grade 1 or 2 diarrhea. There can be occasional mucositis, but tolerance thankfully is not. So that in mind, certainly then tolerance, it is the financial toxicity which the patients have, which is an issue. If point is not considered, osimertinib according to it for EGFR mutated.
Great. Yeah, I think those are all the things I thought, at least in 2022, we have, at least from the surgical side, if not, there is a little more buzz on segmentectomy. Of course, a lot more buzz on the adjuvant options also in early stage lung cancer. Previously we never used to bother about molecular markers, and now, of course, you do EGFR. Do you do ALK as well, Rajat? This is my final question, and then I'll hand it over back to you guys.
So ALK, there is data of ALK in adjuvant setting, but it is not yet approved by FDA. It is not a mature data. So as of now, if I have to choose the molecular markers for adjuvant setting, I'll not be comfortable doing ALK because that will not be the standard of care.
Perfect. So a lot of exciting data of molecular markers, especially in the adjuvant space as well. A lot of data from IOs as well. So I think a lot more to choose, and we have a lot of options. And treatment of early stage lung cancer is also becoming more and more complicated nowadays. And I think thanks to it, because I think the need of the hour is that we know that barring stage 1, when it comes to stage slightly 2, the survivals tend to dip, I think. So it's an effort to sort of improve on the outcomes of these patients, and we are happy to embrace all these molecular markers as well. I think, thank you, panelists. Dr. Sunil, sorry, we couldn't involve you much more in the discussion, but I think I was happy to sort of interact with you all and give a unique case. Thank you once again.
Can I ask one question to Dr. Rajat, please?
Yeah, please, sir.
Yeah, Dr. Rajat, Dr. Rajat, you mentioned that for atezolizumab in this adjuvant, you mentioned about the atezolizumab. So what is the criteria for selection of atezolizumab on the basis of the expression of PDL1?
So it is SP142 clone and the immune cells more than equal to 10%. Immune cell staining more than equal to 10% with SP142 clone. This was the subset in IM power 010, which had the maximum benefit, and this was the subset which has been given the FDA approval.
Right.
Yeah. So exciting. Also,
Am I audible?
Conflicting data on pembrolizumab. Also, we didn't discuss that, but I guess you can discuss that for some other day. But I would sort of thank on the panelists and hand it over back to the organizers. Thank you once again.
Thank you.
Thank you, everyone. Thank you, Dr. Krishnamurthy, sir, and thank you all the esteemed panelists, Dr. Darlong, Dr. Shubham Garg, Dr. Bilal Asif, Dr. Pasricha, Dr. Amit Janu, for a very nice interactive session on a very pertinent topic nowadays. Early lung cancer is something which is a field which is evolving day by day with coming in of so many things. We could have spoken about neoadjuvant treatment also. With the recent ASCO 2022 talking about the Checkmate 816 and the Nardin trial. So we have lots to offer our patients as far as the early lung cancer is concerned, which is always a good thing for us as medical oncologists to really improve the survival of our patients. Thank you once again, everyone. So now we move ahead. After this very intriguing panel discussion, we move on to the metastatic setting in Nsclc. We talk about decoding treatment options for EGFR mutated Nsclc patients. And to talk about this, we have with us Dr. Vikas Goswami, who is a senior consultant medical oncologist at Max Hospital, Delhi NCR. Dr. Goswami, good evening, sir. Is Dr. Goswami there? Pooja, can somebody confirm Dr. Goswami, has he joined?
Yes, sir. I think he has just joined.
Hello, Rajat.
Yes, sir. He has just joined.
Rajat, am I audible?
Yes, sir, you're audible.
Hi,
good evening.
I am extremely sorry. Apologies. Actually, I am traveling and this part of the city didn't have network. Can I start?
Please, sir, please go ahead.
Okay. You can stop somewhere. Is my screen visible, Dr. Rajat?
Sir, yes, it is visible now. You need to adjust the slides, I think.
I'll do that. Is it fine?
Yes, now it is fine. Absolutely.
Fine. Thank you, organizers. I am extremely sorry. So I'll be brief. I'm mindful of the time given to me. So I'll be talking about the decoding treatment options for EGFR mutant Nsclc. So we know that Nsclc has got high incidence and mortality in India and across the world. And what matters and how are we monitoring the various trials? Primarily, it's the PFS, then it's the OS, then there are overall response rates. We also need to be mindful of the brain metastasis, safety and toxicity, quality of life, and patients receiving subsequent therapies. So a brief options available for treatment of EGFR mutation. We have the first generation Geftinib or Lortinib, second generation Dacomitinib, Afatinib, and finally the third generation, which is the osimertinib. Now the issue is, how do you compare? In the lack of head-to-head trials, we have to resort to indirect comparisons. So first thing is progression-free survival. So the first thing that comes is afatinib was compared to geftinib, dacomitinib was compared to geftinib, and osimertinib was compared to standard of care. And we can see that the curves start separating fairly early for osimertinib as against dacomitinib and geftinib. In case of afatinib, the separation starts happening almost after 12 months, and there they had stable brain mets included. In case of dacomitinib, though they had all brain mets included, stable and unstable, the separation started happening at 6 months. In osimertinib, the separation happens at the start of the trial itself. So it is immediate separation. So early separation of PFS curves is shown by osimertinib only. Then again, if we see cross-trial comparisons, the response rates for afatinib are in the range of 70%. They are in the range of 50% for geftinib. They are in the range of, again, around 75% for dacomitinib. Osimertinib is 80% plus. So osimertinib again has shown the highest overall response rates and median duration of response. Then FLORA is the only trial to show overall survival benefit, and osimertinib has a OS benefit with hazard ratio of 0.799, and median OS is crossing 3 years. Now, mind you, median means 50% would do better. So imagine a lung cancer patient with a median overall survival more than 3 years. That's quite an achievement. There is no overall survival benefit for afatinib, and in the Archer trial, though there is numerical overall survival benefit for dacomitinib, however, it is not significant. The p-value was not assigned to dacomitinib in that study. So 28% patients were still receiving osimertinib at 3 years, and 22 versus 25% patients were still on treatment at the time of data cutoff. So osimertinib, as per FLORA trial, demonstrated a superior systemic PFS benefit regardless of CNS status at the study entry versus EGFR TKI comparator. So whether it was with CNS Mets or without or unknown CNS Mets, both the Kaplan-Meier shows immediate separation of curves, and both are hazard ratio is 0.46 and 0.47 in favor of osimertinib as against the standard of care. And of course, the CNS activity is one of the best in class. And this curve shows that it's a subset of patients with CNS Mets, and we can see that the hazard ratio is 0.48 in favor of osimertinib. So significant CNS response to first-line osimertinib in patients with EGFR mutant advanced Nsclc is shown by osimertinib. In terms of safety, we all have used all the drugs, and we know that osimertinib is the most manageable of all. In terms of absolute numbers, grade 3, grade 4 adverse effects for dacomitinib were reported in 63% of patients in Archer trial. In the Lux Lung 7 study, grade 3 or 4 adverse effects were noted in 1/3 of the patients, while in the FLORA trial, only 18% of patients had grade 3 or more adverse effects. So again, the same in tabular form, the in-class effects, whether it is skin side effects, paronychia, diarrhea, or stomatitis, the FLORA study had least of all in all of them, while Archer and Lux Lung had higher numbers, where dacomitinib is the most toxic of the lot as per the data. The same can be reflected in terms of dose reductions. So 5% of the patients for osimertinib required dose reductions as against 67.4 for dacomitinib, and 41% for afatinib required dose reductions. Another way to prove the point, bring home the point that osimertinib is better tolerated is to evaluate the quality of life indicators. So again, we can only take cross-trial comparisons. Flora had worse quality of life indices on various aspects as against, Archer had worse quality of life indices as against the Flora, where the quality of life didn't change much between the standard of care and osimertinib. Very, very importantly, some may argue that we may give EGFR first generation or second generation and reserve osimertinib for a second line. So is it better than giving osimertinib in the first line? We don't have a head-to-head trial, but there are some data to show that osimertinib given in first line certainly is more beneficial. So what is that number? So if we take 10 patients who are EGFR mutant, 2 will die during the first line treatment. Another 2 out of the 8 who progress, another 2 would not be eligible for sampling the tissue for T790M mutations, and another 3 would be negative for T790M mutations. So effectively, only 30% of the patients would be eligible for osimertinib in the second line. So 70% of patients would not be able to take osimertinib in the second line, thereby negating the hypothesis that giving geftinib in the first line, reserving osimertinib may be as effective. So again, the same thing, that approximately 1/3 of the patients will only have access to osimertinib, while 2/3 won't have. Then we have the real world data of 790M mutations after afatinib. So the question is, how many patients after afatinib develop T790M mutations? We have some studies from Taiwan and Japan, whereby 43 and 48% patients respectively developed T790M mutations, meaning that more than half the patients were not eligible for osimertinib after afatinib. So sequencing, starting with the prior EGFR TKI and then treating with osimertinib for T790M mutation, this is not the optimal choice, because a majority of patients won't be eligible for that. Then uncontrollable factors in sequencing are toxicity to drugs, occurrence of T790M mutation, sites of progression, concurrent morbidity, and of course, patient's choice. Then comes the real world data with first line osimertinib. Ample amount of data. This is a heavy slide with a lot of graphs, basically proving that the response rates, the PFS rates are in line with the trial data, and the response safety profile, it's fairly tolerable in terms of grade 3, grade 4 side effects. They are fairly manageable. So because of this, various guidelines starting from NCCN, osimertinib is category 1 recommendation, both for EGFR discovered at baseline or EGFR discovered during the treatment. And similarly, ASCO guidelines also involve osimertinib monotherapy upfront. Some questions still remain. For example, we have the Tata study where they give the chemo and geftinib. We don't know how will osimertinib fare with that. We don't know how will osimertinib fare with combination of, if geftinib can work, why not chemo plus osimertinib? So till those answers are there, osimertinib is the first line choice for EGFR mutant drugs, and it has shown benefit in terms of overall survival, in terms of PFS, in terms of tolerance, very, very importantly, in terms of stable CNS mets. And in terms of fencing, the strategy of reserving osimertinib as a second line seems unfair, but the final can only be given in a head-to-head trial. With that, I conclude. Over to organizers for any questions.
Thank you very much, Dr. Goswami, for this very crisp presentation on the role of osimertinib in the treatment of EGFR mutated Nsclc. In your practice, do you always resort to talking about osimertinib with all your patients who are intending to take first-line treatment for metastatic Nsclc and
So there is no doubt in my mind. Yeah, sorry.
yeah,
Please carry on.
yeah, or you think that while you are discussing osimertinib with your patients, there are certain so-called competitors that you have in mind, and when I say that, I'm talking about one dacometinib that you also spoke about, the Archer study, and also your thoughts on the relay study, which is erlotinib plus ramucirumab. So what are your thoughts between these three options that we have?
So dacometinib has some data specifically for certain mutations, but between the two, I am very clear in terms of tolerance profile. Osimertinib, hands down, is a winner. And for as far as erlotinib plus ramucirumab study is concerned, it is an option. But then, number one, it is not better in terms of cost. Number two, it's a systemic therapy. So in terms of ease of therapy, a single monotherapy drug, osimertinib, which is quite tolerable, is the base. I mean, by default study. One can go to geftinib and erlotinib, and we do that only in cases where patient is not able to afford. Otherwise, in terms of data, there is no question in my mind that osimertinib is the gold standard right now.
Okay. In your experience, have you noticed any untoward side effect of osimertinib, anything which has been atypical, not really mentioned in clinical trials, anything that you can probably tell us, if at all?
So personal experiences do count the least. Honestly, I can't recall any which led me to report a side effect attributed to osimertinib.
Okay, okay. Right. Thank you so much for this very nice presentation. Thank
Thank you.
So after this discussion on osimertinib, it is only apt that we should talk about whether the actual strategy for the treatment of EGFR mutated metastatic Nsclc is osimertinib alone, or do we have any other option? And one of the options that is certainly there as a competitor of osimertinib is erlotinib plus ramucirumab, according to the relay study that we spoke about. And I always believe that to bring out all the facets of two competitor molecules for one particular setting of treatment, we should be having a debate, and this is what we try to do. This is the debate between osimertinib and erlotinib plus ramucirumab as the treatment options for first-line EGFR mutated metastatic Nsclc, and to have this debate conducted between two very expert speakers, we have with us Dr. Shyam Agarwal sir, who's Director Medical Oncology at Gangaram Hospital, who is going to be the moderator of this session. Sir, good evening.
Yeah, thank you, Dr. Rajat, for this invitation and the opportunity. So my job is to set the stage for this particular debate between osimertinib and the combination of erlotinib and ramucirumab. I think the stage has already been set, and the job of the first speaker seems to be have been made easier by the previous speaker. But still, I'm sure he's going to point out many more points in favor of his molecule, which is osimertinib in EGFR mutated non-small cell lung cancer. So I think we've seen phenomenal progress in the last 20 to 30 years in this domain of EGFR inhibitors. and it continues to, lead the way for targeted therapy in solid tumors, as we see more and more drugs coming in, first generation, second generation, third generation, and even now fourth generation EGFR TKIs are being tried in the clinical trials, and then the combinations. So I think so I won't stand between the two speakers. So I'll invite Dr. Kshitij Domadia. He's from Ahmedabad, from HOC Vedanta, medical oncologist and hematologist, to speak on osimertinib in Nsclc. Over to you, sir.
Good evening, sir. And thank you, Dr. Rajat, for this invitation. So I take my liberty to share my screen. Okay. So as Dr. Shamsa clearly mentioned, the state has been set. And this is a debate regarding the first-line management of EGFR mutant advanced lung cancer. And I am going to speak for osimertinib. So before 2018, we had options of gefitinib, erlotinib, afatinib, etc. as far as the EGFR TKI are concerned in the management of EGFR mutant advanced lung cancer. In 2018, we had a FLORA trial, which established the role of osimertinib in this particular setting. And since then, we have come a long way. And since then, we all have good experiences with this particular molecule. We all have used in our patients, and I'm sure that every one of us appreciates this molecule and appreciates the science behind this molecule. So as far as the debate is concerned, there is nothing much to tell for osimertinib, as we all are already convinced that osimertinib is really a good molecule. So the points which I want to make is, can erlotinib ramucirumab replace osimertinib? So more of, I'll be speaking against erlotinib plus ramucirumab. So the important point which I want to discuss first is regarding CNS metastasis. We all know how important it is to manage brain mets in a patient of advanced lung cancer. So if we see FLORA trial, if we see the patient characteristics of this trial, about 1/5 had patients who had CNS metastasis on presentation. And if we compare it with the relay data of erlotinib plus ramucirumab, it seems that they have accepted the defeat from the beginning itself. They have excluded the patients who had brain metastasis. And now this is what we are comparing, the progression-free survival of FLORA versus relay. The number is 19.4 months with ramucirumab erlotinib versus 18.9 months with FLORA. Numerically, it seems bigger, but the point which I want to make here is it has excluded the patients who have CNS metastasis at presentation. So it cannot be comparable like that. We all know osimertinib and its usefulness in penetrating the blood-brain barrier, how well it acts in CNS metastasis, as can be clearly shown in this Kaplan-Meier curves from FLORA, that the curves, they are well separated in CNS mets as well as in patients without CNS mets. We can see the hazard ratios, they're nearly similar, 0.47 and 0.46. We are not able to have, or we cannot have these comparisons with erlotinib plus ramucirumab because the patients of CNS mets, they were excluded in this trial. Now, I am sure that brings to me about L858, and I'm sure Dr. Piyush is going to speak a lot about L858R. The reason is that we all know that somehow in this particular EGFR mutation, EGFR TKI monotherapy doesn't act that well as it acts in the other exon 19 deletion. And if we see the flora overall survival forest chart, this is a subgroup analysis, a forest plot, which if you see the EGFR mutation part in L858R patients, the confidence interval, it crosses the line of unity. So, but the important thing is this is a subgroup analysis. We cannot believe on this. If we are going to believe this, we need to believe that that osimertinib won't act in males, osimertinib won't act in age more than 65, in Asians, even in CNS metastasis at trial entry. So the point is, it should be taken with a pinch of salt. If we see the relay forest plot, the EGFR subgroup, both DEL19 as well as L858 are there on the left hand side of the forest plot. But again, this is a subgroup analysis. If you are going to believe that erlotinib plus ramucirumab acts well in L858 just based on this subgroup analysis, we need to believe that it doesn't act in age more than 65, it doesn't act in non-Asians, it doesn't act in ones who are having liver mets. So the point is, this is a subgroup analysis which needs to be taken with a pinch of salt. So what is the point which I want to make over here is L858R mutations. If we see the data of EGFR monotherapy trials, osimertinib FLORA trial in exon 19 deletion has a median PFS of 21.4 versus 14.4. Absolutely, I agree on this particular fact that numerically, compared to deletion 19, L858R patients, they have a lesser median PFS, as is true for afatinib, erlotinib, etc. So, and if we see the relay trial, forest relay trial Kaplan-Meier curves of deletion 19 as well as L858R, the curves, they seem very well separated from each other, right? With a 19.6 versus 19.4 months. But the point is, based on this data, can we tell that in L858R subgroup of EGFR mutation, erlotinib plus ramucirumab is better than osimertinib? This is how it should not be promoted, because these are completely two different trials. We cannot compare apples from oranges. It is as simple as that. Now, okay, so regarding L858R, obviously this observation means that there is something in it which we all don't know. Probably they are compound mutations, and EGFR TKI monotherapy won't act that well as it acts in deletion 19. Perhaps there can be many co-mutations which are more likely in L858R. In previous trials, the role of deep molecular sequencing was not well established. So perhaps we don't know what all is along with L858R. In short, we don't know much about this particular mutation. But the point is, that doesn't mean that erlotinib plus ramucirumab is the drug of choice for L858R. It cannot be promoted. It cannot be said just based on a subgroup analysis. What about other options? What about using chemo plus TKI? And we all know there are many ongoing trials with osimertinib-based combinations, like osimertinib plus chemotherapy, even osimertinib plus ramucirumab. So perhaps this particular trial, that is Revolve L858R trial, which specifically looks at this particular issue, it takes just the L858Rs and they randomize into either erlotinib plus ramucirumab versus osimertinib. The results are awaited. Perhaps this can guide us further in this debate. Next, moving towards a very important point of toxicity and compliance. We all know how tolerable osimertinib is. If we see the data, grade 3 adverse events are very, very less in osimertinib. And if we see the relay data, there are about 70% grade 3 and more than that treatment emergent adverse events. How can we compare, or how can we give erlotinib plus ramucirumab over osimertinib if we don't have a very robust efficacy data and how can we subject our patients to such high grade 3 treatment emergent adverse events? That is the point. That brings me to the next point of overall survival data. Since last couple of years, we know the overall survival data of osimertinib. We know it is better than the comparator arm. We know the figure, we know everything about it. We don't have the overall survival data as of now for the erlotinib plus ramucirumab combination. Next point is regarding cost effectiveness. So if erlotinib plus ramucirumab is equivalent in efficacy to osimertinib, but if it is cost effective, definitely one can consider using it in their patients. But it is not the same. But it's not the same. There is no any cost effectiveness which can be seen. Moreover, it's a parenteral regimen. It needs infusion. It needs at least a daycare admission. It needs labs. It needs some important parts to be monitored. And on top of that, you are getting 70% grade 3 treatment emergent adverse events. I'm sure Dr. Piyush is going to tell that post erlotinib plus ramucirumab, you may get T790M, the patients may get osimertinib, and by doing such sequencing, we can delay the time to chemotherapy. Now, regarding this, we have known osimertinib for quite a few years now, and our understanding of post osimertinib options, they have grown over a period of time. And now we understand post osimertinib resistance mechanisms in a better way than we had in the past. We know that there are many things apart from chemotherapy which can be done post osimertinib. So the world is moving towards doing molecular sequencing and every progression. So that doesn't mean that post osimertinib one can, the only option remaining is just chemotherapy. So with that, I just summarize my talk. Why osimertinib? The USP of osimertinib lies in its penetration in the blood-brain barrier. And that is the first and most important thing which I would like to convey. Second important thing, there is a good overall survival data to support it. We all know how good, tolerable, how safe this molecule is, and how happy the patients and the doctors are while giving osimertinib. We have a better understanding of post-osimertinib resistant mechanisms. And regarding L858R, definitely I can tell osimertinib may be less efficacious in this mutation compared to deletion 19 mutation, but erlotinib plus ramucirumab is the answer for it, or is the drug of it. I strongly oppose this statement that for as T790M is for osimertinib, L858R is for erlotinib plus ramucirumab. This cannot be promoted. We need trials, we need more data to clarify it. We don't know the mechanism, the scientific rationale, why erlotinib plus ramucirumab acts well in L858R. So we just cannot implement, we cannot give patients this particular regimen based on a subgroup analysis. So with this, high regards from my team as well as my institute, that is the HCG Cancer Center Ahmedabad, and I thank you. I thank you, organizers. Thank you, Dr. Shyam sir.
Thanks, Kshitij, for bringing out the salient features in favor of osimertinib. But then I think we do have a competitor combination, I would say, which is the relay study. And I'm sure Dr. Piyush from Delhi is going to defend that in a very serious manner. So over to you, Piyush, to showcase the efficacy of the combination.
A very good evening, sir, and thank you for this. And thanks to Rajat for setting this, opportunity for this wonderful debate. And Kshitij, I absolutely agree with most of your points, but of course, there would be certain things I would, put forward. Great talk, Kshitij. So the best drug first, and that's what we are talking in this debate right now, the ideal strategy. And we understand that, we have seen how biomarkers in 2022 for lung cancer have evolved. We understand that EGFR is one of the most important one which we look at. And there are the two main ones which are actually there in almost 90% of our patients. These two ones, the two are the ones, the exon 19 and the L858 are almost equally distributed. Slightly exon 19 is more. So it's almost quite equal. It's not that, percentage wise that the so-called bad subset of exon 20 would be lesser. So when we go through the NCCN guidelines, of course, we understand that osimertinib stands where it is, and it is because of the reasons what Dr. Kshitij pointed out. And of course, when there are other recommended recommendations, so these are also options and they are there for a reason. And Dr. Kshitij has already covered this, that this is because of osimertinib in 2018 FLORA that changed our practice. And you can see this picture of brain metastasis beautifully over there. We can actually vouch that if in case such a patient comes to our clinic, all the medical oncologists would actually go for it. Beautiful progression-free survival curves, both in the all comers as well as the CNS metastasis. So this is what we were actually waiting for, the EGFR TKIs to deliver penetrance in brain with osimertinib, the third generation, eagerly awaited. So this was very nicely, shown by this particular trial. Overall survival, very impressive. So you can see that, osimertinib eventually had a 38.6 as compared to the comparator EGFR TKI. We must understand the comparator over there was the first generation. So now where is this particular thing coming? And Dr. Kshitij did tell, and he did accept that he does not have answers for exon 21. The L858R, why osimertinib is not doing well? Why is it standing just at a hazard ratio of 1? And if there is something doing well, he says that he cannot say, on a basis of subgroup analysis. I understand subgroup analysis definitely are something where you cannot take everything. You need salt and pepper, but of course you need, you need to have some hypothesis and some discussion coming up till you get the answers from Revolve, what you just said. So we get worried once we see osimertinib failing. You actually consider most of the patients went on to cytotoxic chemotherapy once osimertinib failed. And then, of course, when you have the other first generation failing, you had patients an option of osimertinib. And he also told that, yes, T790M comes up. And that is why, you see this, it is not just the T790, you see this particular mutation over there, EGFR C797X. And you have nearly 29% of it if it is a later line osimertinib. You do not have it if it's a first line osimertinib. And mind you, that this sort of mutation, you can use a first generation TKI back again if in case you have this mutation coming up in a later line osimertinib. Why is it so important? Because of course, the other mutations are there. For now, you have the access to various patient assistance programs and drugs. But of course, when we talk about patient assistance programs, they're not actually very easily available. Clinical trials, not very easily accessible. So actually in practice, where we practice actually, a lot of these things are just quite hypothetical. And I totally believe that osimertinib is Mr. Bolt, and Mr. Bolt still believes that he can still do the best. He can still do better than what he's doing. And especially if it's a 400-meter dash, the question is, would he go alone over there? No, with such hurdles coming up, would he be able to just go through the 400 meter, and that could take off the sheen probably. So this is a poor disease subset, and something more needs to be done, which needs to be appreciated. And this is one presentation I came through, and this was presented in the ELCC. What would be lung cancer in 2030? And one important thing which would be, looked upon is, of course, making a great drug. Osimertinib is a great drug, and it should be, projected to its further heights, so better heights. So making a great drug work better is something which is going to be really important. And there are trials going on to make it go better, actually. And you see 2 trials over there are actually with anti-VEGF. There is some potential over there, and the potential lies that, the VEGF pathway along with the EGFR pathway, there is a co-stimulation, and the VEGF pathway actually can give rise to resistance to the EGFR pathway mechanism. There is a lot of crosstalk. And if you inhibit that, probably you might actually get some way to sort of delay the resistance. And I said that, there is no access when you actually fail a great drug, not so easily. So this particular hypothesis of the doublet, actually VEGF and EGFR has caught the attention of the scientific community. And there are trials actually, and this one is an example where a good PFS is being seen. It is the VEGF which is important, probably along with the EGFR, I think so, when we are looking at it. So relay is one example of it, where we have already got this information. Dr. Kshitij has spoken about relay as well. So this is what it was, and clearly there was a PFS benefit, which was the first, primary endpoint. And of course, I agree that there weren't patients with brain metastasis. So that was something that they acknowledged, that this is not the subset probably they could take in. Yes, and this was a pre-planned subset analysis, Dr. Kshitij. So you have EGFR exon 21 straight coming up, that data, pretty impressive. I mean, that is, you have shown a comparative data of all the TKIs doing what they are doing in the late 5-8R. Here you have this particular combination doing something important. Yes, you said that grade 3 toxicities, but then we understand as medical oncologists that hypertension you see as grade 3 toxicity could be very well managed over there. So that's one important, and I'm sure we all are giving bevacizumabs managing hypertension pretty well. So we can see that, it's the theme is that anti-angiogenesis is not necessarily be a expensive molecule like ramucirumab, but very soon I have heard that, probably we might get a biosimilar. So probably the cost might not be the only thing which we are seeing. So synergism is there, definitely synergism is there, and this is working somewhere. And you talk about compound mutations being present. Of course, there is data with TP53 and ramucirumab and erlotinib doing well over there again, with the median PFS benefit still being reflected, and a hazard ratio stands over there 0.56. And the PFS2 data is impressive in both the mutations. So this is very important that, not reached in L8 5-8R. That is so important, that the PFS2 data, and again, this is a subset analysis, I agree, but this from subset analysis only you can have the various trials evolving. And you see that the T790 is actually not the chances that this doublet would not have a T790 eventually as compared to erlotinib. So you see 43% versus 47%. The doublet probably will have or throw up a T790 as equally as a EGFR's first generation TKI would have. So you can actually then have osimertinib coming down the line over there. And time to chemotherapy, of course, is something. This was presented as a subset analysis again, but then it was delayed, and again, it is the time was not reached versus the placebo or lorlatinib 26.3 months. And you have trials. That's why you have these combinations coming up again, beyond osimertinib. So in the era of precision medicine, we are talking about in the era of precision medicine, we have to understand that we need to use the best drugs in the best way. Sequencing becomes an important point over there. We cannot use the hammer approach. During Flora design, best challenger was first generation TKI. And now if we have a doublet data, we are forced to think that this could be there, but in a certain subset of patients. With relay, we need to think about L858R patients. And therefore, even the best can still do better if it's a 400-meter. Teamwork is very important, and you can get, difficult situation, win in difficult situations if you strategize well. Thank you.
Thanks, Piyush. That was wonderful. I think Kshitij will take 1 minute to rebut if he wishes to.
Yeah, thank you, sir. Thank you, Dr. Piyush. That was a wonderful talk. We all enjoyed it hearing. So the only thing is, yes, definitely, L858R is an unmet need in L858R. And probably in a couple of years, we would be able to know it in a better way as how to manage L858R. Probably the combinations along with EGFR TKI, they are way to go. Maybe a combination with a VEGF inhibitor or something. But as of now, with the available evidence, I can say even in L858R, it won't be appropriate to use unlotinib plus nivolumab versus if you're having an option of an oral TKI, very well tolerable, very well safe. In such scenario, I think I would still prefer osimertinib.
Me too.
Okay, so Piyush, last minute comment before I give my expert comments.
I totally acknowledge, sir, the points what Kshitij made, and it is very difficult to actually convince a patient, I mean, leaving the debate apart, convince a patient about IV therapy if you do not have a robust data. But of course, probably the data is there. So,
right. Yeah. Great. So thank you. And let me, sort of sum it up and give my expert comments. One thing is straight, which I think both the speakers acknowledge, that L858R exon 21 mutation is definitely a different disease, which needs to be addressed possibly in a different fashion. It's more aggressive, and the reason for that, as we understand, is compound mutations or the other passenger mutations, which possibly are responsible for developing resistance. As you treat them with the first, second, third generation TKI. So I think we have to acknowledge that fact that L58R does need, separate attention, and it's relatively, I would say, an unmet need. So if we agree that there are more mutations, well, then I think a study needs to be done that what are those mutations which, along with the L858R, are responsible for the TKIs not working. So like you showed the P53, there the relay study is showing that the combination is working. So I think these are some new things with the availability of CJP or NGS upfront. You can not only identify the main mutation like EGFR, but you can also see the effect of other compound mutations or passenger mutations on the efficacy of these molecules, whether a single drug or a multiple drug. There's nothing to sort of defeat the CNS penetration of osimertinib. A patient who has CNS disease, stable or otherwise, certainly the combination of erlotinib and ramucirumab is definitely out. And the final thing is, whether you believe in sequencing or you believe in the DASH, which Dr. Piyush mentioned. So I think any malignancy today is becoming like a marathon, and you have to be prepared for multiple sequencing, multiple agents. And, so it becomes at times difficult for the physician to decide which is the best molecule or a combination to begin with. But I think with these kind of issues which we have at hand, we really need to, suggest or advise our patient as to, you have the third generation TKI, followed by sequencing for identifying the mechanisms of resistance. or else you have the combination available, and then you can sequence, and nearly 50% can be responsive to a drug like osimertinib. So I think there are points on both the sides, and that is why the debate is there. But I think with the understanding of the malignant disorder emerging in the near future, and new drugs coming in, osimertinib plus ramucirumab trial maybe in 1 to 2 years will throw some light on the efficacy of this combination. So I think it's a long way to go, because 2-3 years is actually nothing. It still remains an unmet need, because everybody is going to relapse. It's not like immunotherapy where 20-25% patients maybe get cured. Then none of the patients are getting cured. So 2.5-3 years is just nothing for a 40-year-old man who or a woman who develops this disease. So we have a lot to understand on the biology of disease and discover new drugs to target the new mechanisms of resistance so as to enhance the life of our patients. So I think those were my comments. So I think I'll hand it over to Rajat and the organizers for further deliberations. Thank you very much.
Thank you so much, sir, for very nicely summing it up. Sir, do you think that it is very rare for us to see in a debate that both the speakers have been so calm in their approach and yet very pertinent with their points? So I think we should congratulate both of them for doing their role very well.
Yeah, both did a wonderful job. Thank you.
Right, so thank you so much, and your expert comments are always the icing on the cake.
Thank you.
Thank you for being there, sir. So thank you, Dr. Kshitij, Dr. Piyush, for being there and discussing the points very well, as pointed out by Dr. Shyam Agarwal sir as well. So after this debate, we move on to the next session, which is the panel discussion again, which happens to be on the learnings from ASCO 2022. And specifically talking about the targeted therapies in metastatic lung cancer. And to discuss about, we have with us the moderator, Dr. Bhavesh Poladia, who is a consultant medical oncologist at Thangam Hospital and Cancer Center from Tamil Nadu. Dr. Poladia?
Yes, thank you. Good evening to, I'm there. Good evening to one and all. Thank you, Dr. Rajat, for the invite. I'll just like to see who all are there. I think Dr. Monica is there, Dr. Satyankar is there, and Dr. Taha is there. So I think 3 out of 6, 3 panelists are there. So maybe Dr. Rajat, I will involve you in between. I'll just share my screen. So I hope my screen is visible.
Not yet. Yes, now it is visible.
Okay, fine. So warm greetings from my center, from Namakkal, Thangam Cancer Center. So it will be basically a case-based discussion, and we'll see how the practice is going on after this ASCO 2022, whether it has changed or it remains the same. Let us start with the case history. We are already, I think, late by 10-15 minutes. So this is a very common scenario. We see it in our daily practice. A 54-year-old gentleman, former smoker, 20 pack years, and he has no past medical history except for type 2 diabetes, which is well controlled with oral hypoglycemic agents. Otherwise, the PS is 0. There is no issues with him, no symptoms with him, and he suddenly presents with pleuritic chest pain and a shortness of breath over the past 1 month. So obviously, patient comes to us, we evaluate the patient clinically and then order for scans and a biopsy to confirm our diagnosis. So CT scan was done and histology was confirmed. On the scan, patient was showing an inoperable mass in the lung, which was around 4 to 5 centimeter. And CT scan of the abdomen was showing again an adrenal met. So practically, this patient was metastatic, and a biopsy was done from the primary, which showed that it was adenocarcinoma. So it was labeled as stage 4 Nsclc. So I think I'll ask first Dr. Monica, how comfortable you are with this report, stage 4 adenocarcinoma Are you happy with this, or you want to do something more, or you just want to start treatment on this basis?
I would like to go for the driver mutation testing and PDL1 testing, sir.
So does it make, I mean, according to you, why it is so important? I mean, you could have started chemotherapy as well.
If there is any driver mutation positive, then we could use the TKIs, either EGFR, ALK, or any other TKIs with much lesser toxicity as compared to chemotherapy, and also because the treatment becomes much more easier for the patient to take, also because it's a simple tablet that they have to take every day. That's why I would like to see if other than chemotherapy, we could use any other targeted therapy or immunotherapy, whether that's also an option if there is PDL1 expression.
So very rightly said, Dr. Monica, because there is a big French data and even American data, which shows that if you miss this personalized medicine in lung and you keep giving chemotherapy alone, your survivals are actually half. And if you can able to find a target, which is usually possible in nowadays, almost in 50 to 60% patient, you will find some target. And if a patient gets a targeted therapy, the survivals are double. So that is why it is very important to not to leave the patient at here, and we have to see further what else is the specific mutation which is there. So as we did the same thing, and from a limited panel which was done, in that a molecular panel showed EGFR mutation to be positive. Deep sequencing showed exon 21 L858R, which was actually the discussion right now. In fact, I can take a poll that who are for osimertinib and who are for something else. So, Dr. Taha, after I hope you have gone through the debate, and you must have seen such patients also in your clinical practice. So, what's your choice for such patients?
Sir, actually, yeah, I was part of the debate. And before I could hear the debate, my choice was osimertinib. But now I think I'll have to start thinking about it again, to rather for a combination of Arlo with Bev rather than osimertinib.
So for 1 month or maybe less than a month difference, do you want to escalate the cost by 2.5 times to 3 times?
Sir, but I mean, end of the day, the response rates, the compliance, all those things I feel would make, I mean, the end of the day, the decision would on all those factors, sir.
So I'm confused. I want to understand what will be your choice, osimertinib or something else?
Osimertinib, sir.
Osimertinib. Okay, great. Dr. Satyankar, do you agree with him, or you have some other option, or you counsel the other way?
Yeah, my choice would certainly be osimertinib only, because as discussed in the last previous session, there's no hardcore, strong evidence to say that L858R, Arlo plus Ramu would be a better choice, although it's not given in the options. So still, I think I would go with osimertinib only.
Suppose if it is a better choice, do you want to, because the osimertinib is costly, ramucirumab is costly, would you, suppose if osimertinib plus ramucirumab gives a good outcome, would you like to replace osimertinib plus bevacizumab instead of ramucirumab? Dr. Satyankar, can you comment on that?
Scientifically, if you take, then osimertinib definitely scores because it's a single drug, oral, well-tolerable drug. And the best part is that if you have to extract the maximum benefit out of this drug, then you have to give it upfront rather than delaying it at a later stage. So, and I think Ramu is not that well tolerable also, having that so much experience with stomach cancer. So I would still go with osimertinib.
Okay, point well taken. Dr. Monica, you have been from Tata Hospital. Probably you must have recruited some of the patients on Geftinib plus chemotherapy arm. What is your choice? You were able to give osimertinib to everybody, or your choice was more for Geftinib plus chemotherapy?
Sir, so finances is the main issue. So otherwise, tolerance-wise, because osimertinib is much better tolerated, and obviously, addition of chemotherapy would mean more toxicity, especially if the patients have comorbidities and they are elderly. In an otherwise fit patient, geftinib and chemotherapy is also a good option. But if there is comfortable financial for one reason that the tolerance is much better.
So point well taken. I think if,
my first choice also would be osimertinib. But again, considering the finances, geftinib and chemotherapy will be a good option. A very good option.
So that's a key point. Like not every patient which walks in your clinic will be able to afford osimertinib. So we have a second choice, which will be geftinib plus chemotherapy, which is obviously having equal effect and has less, the cost wise, it will be lesser. But definitely it comes with side effects. Almost 60 to 70% patient did have some kind of side effects when it was given. And we have to choose our patient physical condition also according to that. So nevertheless, osimertinib remains a choice if it is a scientific discussion. I will involve Dr. Rajat over here, and I would ask out of these four, sorry, Dr. Rajat, what will be your most important factor, whether efficacy, safety, QOL, or OS? What do you think is the best, or what you like to be the best in your first line therapy?
I'll keep efficacy and overall survival as same points. Basically, they are basically probably the same thing said in two different words. Probably I would say that. So efficacy and OS for me is the same, and this is going to be the most important. And along with that, definitely quality of life, and then comes the safety part.
Okay, Dr. Ajay Singh has joined us. We'll ask Dr. Ajay.
Yes, sir. Good evening, sir. Sir, for me also, first I think important thing is more for me is the safety.
You are muted. Can you unmute and speak, Dr. Ajay? Yes. Yes, Dr. Ajay, we can hear you now. Can you tell us?
Safety and efficacy as the first point, and I'll keep the OS as the second point.
Okay, so we are actually divided over here. No issues. So I think most of the time when patient is asked what they want, the 80 to 90% patient wants longevity of the life, which is very important. So OS becomes the hard point, or the efficacy becomes the hard point. And definitely, if it is associated with safety and good quality of life, probably that is the best choice which we have to run first.
Sir, just one point I want to make. I think while seeing deciding, we need to see the profile of the patient also. Suppose young patient, then definitely longevity will be the obvious first our treatment goal. And if we are seeing patient who are 70, 80 years, then I think safety and efficacy will be the more important thing in that scenario. Because recently we had a patient who has early lung cancer, 50 years, and we were debating on whether to give EGF. He was EGFR for whether to give EGFR targeted as an adjuvant. So as per criteria, he was not fitting for any adjuvant therapy, but he was very concerned regarding what will be his DFS and OS. So that time, based on discussion, we decided to, in spite no any evidence to give, but we decided to give adjuvant EGFR directed therapy.
Sure, that is an acceptable option actually. In frail patient or where you have doubt, probably giving an adjuvant TKI, EGFR TKI is a good option. Rather than not giving anything and risking the patient to come back with cancer, and maybe this time it will be metastatic cancer. So one more point which I want to understand is how routinely you are doing a brain MRI when we already know that the patient is stage 4. If the patient is not having symptoms, not symptomatic for the CNS disease. So Dr. Monica, I'll start with you. Do you do a brain MRI for all stage 4 patient, or if the symptoms are not there, you just start the treatment otherwise?
I'm not doing it routinely if they are not symptomatic, sir.
Okay, Dr. Ajay, what is your comment? Do you do it in Tata every day? I mean, every patient?
No, sir. With asymptomatic patient, we are generally not doing. But now actually we in Tata we are doing some projects. So as per projects we are doing for all molecular positive, but as a routine we are not doing for asymptomatic patients.
So, Dr. Rajat, what is a usual scan? Is it a PET scan or a CT scan which you do for the evaluation? Because if you do a PET scan, the brain is already imaged and you find an asymptomatic brain met. Does that change your management or it doesn't matter?
So I always do a PET scan for all my lung cancer patients, be it a patient where only a CT scan of the chest is done and there is 1 2 to 3 centimeter lesion. Even then a PET scan is warranted to really see what is the staging. Even if the patient is metastatic, suppose a CT chest showing that there is a lung lesion, there is some pleural effusion, and there are some bone metastasis, even then a PET scan is warranted and it should be done so that you can scan the whole body and look at the volume of disease, burden of disease, and then take this scan as a baseline and then plan the treatment and then eventually compare. So PET scan is definitely the way to go ahead. Talking about brain metastasis, the scanning of the brain should be done, and this is what is recommended by NCC. And also, if the lesion is more than T1A, the scanning of the brain should be done. There are many implications of it. Of course, agreed that if it is an asymptomatic brain metastasis in a patient who's a stage 4 by extracranial dimensions also, we are not going to really manage it by giving radiation or by doing a surgery, but then at least you know that there is brain metastasis. Suppose you do not do a brain scanning, go for osimertinib, and then later patient complains of mild headache, do a brain imaging, comes out to be a brain SOL, you probably would think that I was on osimertinib, it was supposed to work in the brain, was it there in the beginning or not? So, you are a little in a dilemma at that time. So proper scanning should be done, and also since it is backed by guidelines, then why not?
Absolutely. So Dr. Taha, as Dr. Rajat would do, I hope you also must be doing PET scan for patients, and a patient is having asymptomatic brain met, which is there, and will that change your management, or irrespective of the brain met which is asymptomatic, your management would remain same?
Yes, sir. So as discussed, preferably a PET scan before starting treatment. Now, if you find an asymptomatic brain met, then I don't usually insist on any other treatment form. If patient is planned on a TKI, just continue the TKI. Unless patient is symptomatic, then only a whole minority or anything.
So you will, if patient is asymptomatic, does your management change, or
I don't address it, sir.
You don't address it. Yes. But will you keep that in mind, and will you choose your TKI according to that, which is a better brain penetration?
Yes, that will be the part of discussion.
So it will do change your management by choosing what drug you will use.
Yeah, that was yes, sir. Yes, it will.
Yeah. So exactly that is what I wanted to ask. Okay, so I think it is very clear that a PET scan has to be done, as Dr. Rajat mentioned, which gives us a clear idea of all the disease which is present in the whole body, where it is, and that will have implication as even in choosing the first line. Secondly, it will also not keep the patient in dark that suddenly the treatment is going on and the brain metastasis has come up in the next follow-up. So that is also something which we have. That is a good point Dr. Rajat made. So it is just a hypothetical scenario. If PDL1 was positive, do you favor to give IO? I'll ask Dr. Satyankar. So if the IO was there at your disposal, patient has all the money in the world, PDL1 was positive with this EGFR, which is positive, would you go ahead and give IO? Are you impressed by the IO data more than the EGFR data? Dr. Satyankar? Dr. Satyankar, are you there? Maybe I think I'll ask Dr. Ajay. Dr. Ajay, can you take that question? If you have a coexistent EGFR and you also have an PDL1 positivity, and it is like more than 50%, do you err towards giving IO first?
No, sir. At present, so no, sir. Definitely, we are just targeting EGFR. For targeting driver mutation
specific reason?
So because the data is not favoring the immunotherapy response or survival outcome in favor of immunotherapy. That is why only in relapse cases, sometimes we have started giving ABCP regimen. But in upfront setting, definitely we will not prefer IO in these driver mutation positive patients because of the data which is not showing any benefit.
So suppose even if it was a PDL1 50%, more than 50%, would you like to start in that patient? Or even those patients are out?
No, sir. Even we have seen patients who are having PDL1 90% with EGFR. We still don't prefer to add immunotherapy in the driver mutation positive patients.
So that's right. Yeah. That's very right, actually. If we have a target, targeted therapy has to be given first. And IO becomes a second choice or a second line choice, basically. Not a second choice, but the second line choice. This is very, very established. And actually, there are few subsets or few targeted therapies in which if you use IO first, in spite the target is there, actually there is a detrimental survival. So that is why even when there is a target, definitely you have to go ahead with the targeted therapy first. Dr. Satyankar is back. Okay, do you want to comment on this?
Dr. Bhavish, if you go through all the immunotherapy trials, none of them actually include ABCP regimen in the second line.
So post osimertinib, usually this is the only thing but we left, because if we start with osimertinib, probably very difficult to go back and give any first or second generation unless and until we have a specific mutation, like which is a driver mutation, and apatinib or dacomatinib will work on that. But if we cannot go to the first and second generation, the next thing is to either use chemotherapy or use chemotherapy plus IO combination or just IO. I think these are the only options we have later. So coming to the second line, so very, very important. The point which was discussed initially also, that we have to use the best line first. So the basic reason why we have to use the best line of treatment first, because majority of your patients will not even go to the second line. So Dr. Taha, can you tell how many of your out of 100 patients you must have treated for lung, how many patients do go for the second line?
It's more or less a similar figure, around 30 to 40%.
Okay, Dr. Ajay, in TMH, how it is? Everybody goes because everybody has been a good follow-up. Probably everybody receives the second line.
Yes, sir. Generally, we start in second line, but we prefer to do re-biopsy to see what is the resistance mechanism or transformation, and based on that re-biopsy report and molecular report, we decide treatment. But we definitely most of our patients get the second line treatment.
So that's very encouraging, actually, because in private practice outside, we are not able to give almost 1/3 of our patients going for the second line. Usually either they will be deteriorating on their general condition, or they have already exhausted the money in the first line. There are various reasons because of which they will not come up for the second line. And Dr. Monica, in your practice, how many patients do you do a second biopsy when the patient comes with recurrence? Do you go ahead and take a biopsy from that, from the metastatic side or the new site?
If they're progressing on the first line EGFR TKI, I would suggest a biopsy from whichever site there is new metastasis or wherever it's progressing. I do suggest for a biopsy, sir. Although like some of them, it's technically not possible because of this, the site of metastasis may not be accessible, or a patient is not willing, or the general condition is not good. In these scenarios, I avoid it. But otherwise, I do suggest for a repeat biopsy. So in these patients, I think I can say that maybe about in about half of them, I'm able to 1/3 to half of them, I'm able to do a repeat biopsy.
Okay. Dr. Rajat, coming for the report of the second biopsy, it shows the same mutation. EGFR mutation is there. PDL1 is still more than 50, and you have failed on osimertinib. How confident you are to use IO at this point of time?
Post EGFR TKIs, we don't have much evidence of immuno-oncology agents. I would like to see whether we have the typical resistance mechanism mutations of osimertinib, whether it is c-Met amplification or C797S mutation, which is there or not. If at all that is not there, I can counsel the patient that there is one option of going according to the IMPAR 150 study, where ABCP regimen was given, and about a few of these patients had received EGFR TKIs in the past in the first line. But then that also, the quantum of benefit, we have to really weigh the risk versus the cost versus benefit ratio. So if the patient agrees, then ABCP regimen can be used. But then if the patient does not, because of the cost benefit ratio, then probably chemotherapy is the way forward.
So have you personally used ABCP regimen in any patient?
ABCP regimen I've used not in second line, but in first line. I've used in 2 patients. Both these patients had an approximate PFS of maybe 10 months, 9 months. This is what it was. There were no alarming side effects. But the dose of bevacizumab which I gave was 7.5 milligram per kg, and that was because of the cost issues. So, I mean, that also needs to be taken into consideration. And also, one patient I split paclicarb into day 1 and day 8.
Okay, basically that is what I wanted to know, because I think the toxicity is something which is very difficult to handle the ABCP regimen. And of course, it is not like you are crossing 1 year, 1.5 year, 2 years very easily on that regimen. So even though first line, the best line, but probably not the best actually. So actually in ASCO 2022, there were many studies which were actually for neoadjuvant, because now the concept is coming that neoadjuvant therapy has to be aggressive in patients who are operable, like even in resectable patient. The theme is to give the best therapy there. So people are combining chemotherapy plus immunotherapy, getting the MPR. So that is called as the major pathological response, and that is what is somehow is a surrogate marker for overall survival. That's what they believe, and that is what most of the immunotherapy companies are working on, agents like that. But in the metastatic setting, what I would like to discuss or just allude is there are 5. These are new 5 targets which people are actually trying to target. The TROP2, we must have heard it before also. It's a transmembrane glycoprotein, intracellular calcium signaling transducer, highly expressed in solid tumors, including the lung cancer, the Nsclc. It is more overexpressed in squamous cell rather than the adenocarcinoma, and it is associated with poor survival. So we do have to identify and try to target that. The high TROP2 expression, which are associated with lung cancers, are having a very high lung cancer specific mortality. So if we see the lung adenocarcinoma, the TROP2 is seen in almost all 100% patients. But if you see the squamous cell, it is roughly around 92%. But that is not important. The more important thing is the high TROP2 protein expression, which is actually more in squamous cell carcinoma than in adenocarcinoma. And there are a number of studies, including the DATO-DX. It is just it's an ADC which combines the 2 agents, and alone itself and with combination with chemotherapy and IO. There are multiple trials are going on, and they are seeing whether it is actually giving some benefit over and above the single agent. Even in the same stream, even sacituzumab, which has already made good, nice waves in TNBC, is also being studied in the lung cancer also. This is the phase 3 Tropion Lung 01 study schema, where this molecule is being studied versus docetaxel. And of course, the EVOKE-01 phase 3 study using sacituzumab versus docetaxel. So we'll see what these reports will tell us in future. This is one more molecule, NKG2A. Again, it is a target. It is a target which is expressed on the tumor infiltrating cytotoxic CD8 plus T cells and NK cells. And by expressing the HLA-E, the cancer cell actually protects themselves from killing by this immune cell. There is one more molecule, CD73, which is also seen, and this is the COAST phase 2 trial, where it is actually randomized into 3 arms. First is the regular durvalumab monotherapy arm. This is the patients of post-CTRT patients, not the metastatic patient. The second arm is durva plus olecluzumab, which is anti-CD73, and durva plus monalizumab, which is the NGK2A4. And we'll see what happens. We don't have the answers for that, but probably there are multiple other trials which are going on in combination with these molecules, and results are still awaited. HER2, we all know it has made a good impact. It is seen in almost 3% of the Nsclc non-squamous patients. And TDX is one of the molecule which is showing promising results in MBC HER2, in low HER2, and even in very ultra low HER2. So the same phase 3 Destiny 4 trial is looking for the same patients who are naive, and it is in first line setting, where they are having or harboring the HER2 exon mutation 1920, and they are receiving the standard of care platinum plus pemetrexed plus pembrolizumab 3 weekly versus the TDX. TIGIT is again one more marker which is very widely established in multiple different cancers, and also to overcome the resistance in the immunotherapy. So many of the studies are ongoing, which actually are combining immunotherapy with anti-TIGIT antibody and looking for a better result. So there are multiple molecules which are there and which are in trial. Many of them will probably have a positive effect, and we will be able to use it in near future. So new targets with novel mechanism of action are being explored in the lung cancer. We all know that. And this includes those which are antibody drug conjugates, ADC, as I showed you the DAPTO TDX, which alter the tumor microenvironment and immune checkpoint inhibition. So actually it can be used even post immunotherapy, and it will still show some action. That's what is expected out of it. And combination of such novel agent with existing therapy are being studied in the trial, and probably they are expected to improve the outcome. So we not only have agents which can be used alone, but it will be usually used in combination to enhance or give us a second and third line, establish second and third line therapies. So if any question which I have not mentioned or I have not discussed, or some burning question is there, we can discuss that, or some comment from Dr. Rajat.
No, I think almost all the important aspects of this particular domain of lung cancer have been covered. The newer targets are there for us to really delve deep into in the coming few years, and then if these targets they mature more and we are able to find these targets, then our patients are going to benefit more. I think the new all these targets, and probably if they are not there, then we start with chemotherapy. With these new agents, new targets coming up, even the available NGS tests have to evolve, and they have to add to them these targets, so that we can come to know whether we are having these in our patients or not, and then accordingly counsel our patients.
Absolutely. I think I take that is a very important point Dr. Rajat made, because we have to slowly do more and more NGS in our patients. So in case if we do get a target, and if the patient is affordable, very good. If patient is not affordable or patient can be put onto some trial, I think that will be a best way. That will be like an investment of some couple of thousands for those patients. So I'm handing over back to the Dr. Rajat.
Dr. Bhavesh, one small little question.
Yes.
Have you ever come across double mutation? Like I have a patient, yeah, who had ROS1 has EGFR. So how to choose?
That's a very difficult thing to choose actually. Many times I have actually discussed with Dr. Kumar Prabhash also that if we get EGFR and ALK both positive, because we did have some patients like that. So what he told that rather than combining both together, we can go one by one. And usually he would like to start with anti-EGFR therapy. And if that therapy fails, then probably he will put, and it is not working as expected. Like if you are putting an osimertinib and it is not crossing a general PFS of reaching up to 15 to 18 months, then probably that is not a good driver, and probably ALK is the driver, and then time you can switch it. So there is not one answer for that, but practice-wise you can use which is one after the other. That's what we can use. There are certain studies actually going on to see combining both the agents, but we don't have specific answers on that.
Yeah, just to add to this, there is one other way. Of course, there is no foolproof way, but there is another way to find out is that if we really go to our molecular pathologist and ask them about the mutation allele frequency, and if the mutation allele frequency for one particular mutation is higher than the other, then probably that is the driver mutation, and we should go ahead with that particular target therapy first, followed by the other.
That's a good point. Even in IHC percentage wise, I don't know how much we can depend upon IHC percentage, but I think going by the allele frequency is a better way, what Dr. Rajat is mentioning.
Right.
Right.
Does that answer your question, Dr. Satyankar? I think we can.
Yeah,
okay,
right. Thank you so much, Dr. Poladia, for being there and conducting this panel discussion in a very interactive way and bringing out all the very important points. Thank you. And I also thank all the panelists for being there and taking part in this discussion and sharing their valuable thought processes so that we can improve our practices from Monday morning. With this, we come to the end of this two-day webinar, which is Current Oncology Update Series Part 6, which was the day 1 based on the oncology the gynecological malignancies, and day 2 on the lung cancer updates. We have delved deep into what new has come up in this field and how can we really improve our practices to improve the survival of our patients. This certainly would not have been possible without the active participation of all the expert faculties from all over India. I thank all of them from the bottom of my heart. I also thank the organizing team members for their painstaking efforts to really chalk out the agenda of the meeting. Certainly, I would like to thank Horizons and their team for again taking the efforts to manage it in such a wonderful way. And last, I'd like to thank the pharma companies to be generous enough to sponsor this particular meeting. So with this, I again thank everybody who's been a part of this meeting and have attended this meeting. Still we see you again. It is a goodbye from us, and have a great evening ahead. Thank you.
Thank you. Thank you so much. Thank you everyone for joining this two-day academic feast, and good night, everyone.
Thank you.